Hello and welcome to the Community Genetics Seminars, and this particular one on the genetic evaluation of a child with autism or developmental disabilities. Thank you for joining us today. My name is Susan Fernbach. I am a genetic nurse and the Director of Community Engagement for the Department of Molecular and Human Genetics at Baylor College of Medicine and Texas Children's Hospital. We are thrilled to be able to offer this video conference for you, and this funding is through the Texas State Department of Health Services in collaboration with the UT Texas Center for Disability Studies. And we have switched from our community seminars to be able to offer this through video conferencing due to the pandemic. We have two speakers today, Dr. Daryl Scott and Ms. Laura Buckner, and I am thrilled to introduce both of them to you. We will have time for questions at the end of the presentations, and you're welcome to type them in at the bottom of the screen in the Q&A box. And you can type your questions in at any point during the presentation. So let me tell you a little bit about our speakers. Dr. Darrell Scott is an associate professor in the Department of Molecular and Human Genetics at Baylor College of Medicine. He's a pediatrician and a geneticist, and sees patients in the genetics clinic at Texas Children's Hospital. In addition, he is leading a laboratory at Baylor College of Medicine looking to identify genes for common life-threatening birth defects. And he and his wife are the parents of 7 children. Our second speaker is Ms. Laura Buckner, and Laura is a licensed professional counselor. She is a former special educator with a master's in education. Ms. Buckner's area of expertise include person-centered practice, trauma-informed care, and advocacy. She uses her knowledge and skills to support families and individuals with intellectual and developmental disabilities to find the lives that they find meaningful, as well as supports and services. In addition, she is the devoted wife to Ron and the mom of 2 young adults, Michael and David. So please give a warm welcome to Dr. Daryl Scott, our first speaker, and we will let him take it away.
Good day, so I'm Daryl Scott. I'm a clinical geneticist, and today I'm excited to be with you today and talk about how we can use genetics to help make personal care plans for our children who have developmental disabilities and autism. This is one of the things that I think about a lot because I see a lot of children in my clinic who have these type of issues. And so if you said, actually, what are the most common problems that I see in our genetics clinic, or we see in our genetics clinic today, probably the great majority, probably 50% or more of the children we see have developmental delay, intellectual disability, or autism. And so again, this is something that we not only are familiar with, but we also really want to be helpful to these families. One of the things that we have learned over time is that the genes or the instructions that are mutated or changed that can cause developmental delay, intellectual disability, and autism all kind of fit in the same group. They all cause abnormalities in either how the brain develops or how the brain functions. As a result, many of the things that we do for children with each one of these disabilities is the same. In other words, our approach is very similar. And so sometimes parents come in and they want me to understand the details of a child, and I'm happy to listen. But when we actually get to our plan, these all kind of fall within one particular group. The difficulty with this is that there are probably thousands of genes that are important for brain development and function. We have 20,000 genes in total, and our brain is extremely complex, the way it's formed and the way it functions. And so it's not surprised that there should be this many genes. But because there are so many genes, it's very difficult to just look at a child and be able to say that this is the gene that's likely to be causative. And that has led us to having some difficulties. Those difficulties have only recently been surmountable because of new genetic testing. So what happens when a child with one of these problems comes to visit me? We actually do the same thing that we do with any child in clinic. I'll take a very detailed medical history. Often that involves reviewing a lot of medical records that have already been written by other physicians and other specialties. I'll take a very detailed family history and I'll perform a physical exam. In order to make a diagnosis, I may be able to do that based on just the data that I gather at that clinic visit, but more often it's going to require a genetic test in order to be able to either make the diagnosis or confirm that diagnosis. So one of the things I think about is I want to be able to explain how genetic testing works to families. So I typically do this in the same way. Let's assume that this long line represents one piece of DNA, or the DNA perhaps in one cell. Well, every cell actually just doesn't have one copy of the DNA. Instead, we have two copies. One copy comes from our mom and one copy comes from our dad. When we do our genetic tests, we're looking for errors in this DNA. And again, when you think about this symbolically, this is a very, very, very long line. But very simply, we're going to do a few tests. One of the most common tests we do is called a chromosome microarray analysis, or sometimes we say CMA for short. The idea of this test is that we're going to look for pieces of DNA that are missing or extra. And so let's say they take this little tiny piece of DNA, and if it was missing, we want to detect that. Or if there's an extra copy of that, we want to detect that. We know that we should have two copies, almost always, of every piece of DNA. But in this particular case, a child may only have one copy, or a child may have three copies. That can shift the balance of things and actually cause problems with either brain development or brain function. Although this test is a very useful and powerful test, it still does not check or look for all the different changes that are possible. So often this is then followed by a second test called whole exome sequencing, or sometimes we just call it WES. Whole exome sequencing actually looks at the letters of the different genes or instructions. And so we often draw a gene that kind of looks like this. We have little boxes. Those are the parts of the gene that makes the very special protein that will be used by the brain to perform some function or to form correctly. And then we have that little arrow in the front, which is the promoter, which drives that gene. It's not necessarily important that you know how genes look, but it's important that you understand that we're only looking at a small portion of all the DNA when we do this test. We have 20,000 genes, and so there's a lot to look at, but we're only going to be looking at the part that actually codes for the protein. In this particular case, we're going to be looking for changes. Here we have just a small snippet of DNA, ATTGTT, but we're going to look for perhaps a single letter change in that gene that may make a difference. That's the power of this particular technique, and we're going to do that for all 20,000 genes in one test. Now, because there's a whole lot of different genes, we're going to find a whole lot of changes, probably between 500 to 1,000 different changes in anybody that we do this test on. Now, sorting out which one of those may be important is a little bit of a challenge. And so what we have to do is get some help from the lab. They have to tell us first whether they think that a particular change is likely to be causing a problem for that gene or instruction. Sometimes we do this by knowing what changes are common in the general population. And we assume that those are probably not going to be very important. Other changes, though, may be very rare and could be very important for what we're looking for. So they'll help us to know about that. The second thing we want to know is whether that gene, which has the change, is going to be important in brain development. And if we can put together a bad change and it's in a gene that does something important in brain, then you have our complete attention. What I want to talk about now actually are just a few examples of families that have really been genetic bridge builders. These are the kind of pioneering families that help us to understand new genes that cause problems with brain development. And I'm going to share 3 examples, but they show us not only how children and families can help us define new genetic syndromes and new treatments, but it also helps us to see how knowing what a child has or knowing the cause of the developmental delay, intellectual disability, or autism can help us make personal health plans possible. And so these are the families, again, who I've worked with personally and have now blessed not only their own children, but also other families by working together with scientists and doctors to find new genes. The first child, or the first family I want to talk about, is this little child's family. They noticed that he was not not normal at the very beginning. In other words, they saw a difference between him and some of their other children. What they noticed to begin with was that he was very floppy, and they also had his neck tilted to one side. By the time he was 1 year old, they had noticed that he had developmental delays, and this was something that was seen not only by them, but also by their pediatrician. And he began to get some extra help. He also had reflux disease and some severe food allergies. By 14 months of age, he was able to stand, but only with the help of braces. So you can see these very large braces that he had on in order to be able to keep his joints where they were supposed to be, because they were so mobile. And so he had to have special braces. And then by 2 years of age, he was able to walk with a walker. And what I love about this particular child is as soon as he could walk, he wanted to run away from his parents, which actually is a very normal thing to do for children. But anyway, he did have to have special help. But because he took these extra steps, he was finally able to independently walk about 2 years and 3 months of age. Now, any of you who know what would be normal, we usually think about kids walking before 15 months of age or at 15 months or earlier. And so he was quite delayed in his walking. By 3 years of age, he still had difficulty with his development, especially with his language development. He also was noted to have a very large head and these super hypermobile joints. And that's the point at which doctors finally said we should start to do genetic tests. So the first test he had was that first test I mentioned, that chromosome microarray analysis. That analysis found a deletion on the X chromosome. This deletion was carried by both his mom and also by this boy. And again, it's not so important that you know the details of what the change was, but it was hard because the lab had never seen this change before associated with a disease. And so they weren't able to be certain whether it caused a disease. Because they were uncertain, of course, his doctor was also uncertain. And maybe it didn't mean anything, because we see many different changes that are normal. And so they sent the boy to me for further genetic testing. Well, I took a look at this particular area and I had a couple thoughts. One thought is that the X chromosome is very special. Females have 2 X chromosomes, but males only have 1 X chromosome. And so if they have a problem with their X chromosome, especially a deletion, they don't have any other copies of those genes to help make up for that problem. And so I began to look at the different genes in this area, wondering if maybe one of them was particularly important for the problems this child was having. I began to think about again, one particular gene, and this gene was called MAGE1. That particular gene was important because in a mouse, that gene has an important role in brain development. In other words, scientists have actually knocked that gene out of a mouse and found these type of problems. And so then again, this began to capture my attention, and I began to wonder whether it could also be causing problems in this child. I then took a look at normal populations. So there's databases that have normal people. And when I say normal, it's just anyone who's basically doing regular things. They have a job, they have a family, but of course, none of us are really normal. All of us have our different problems. But those individuals, we could never find this particular change in that normal population. We then took a look at databases that have patients or individuals who do have medical problems. What we found is that there were some individuals who had changes there. One of the ones that was most important to me was a change that was seen in a child from England. And I was able to know which institution that child came from. And so I was able to reach out to that particular doctor at that particular institution, and I asked him about what were the symptoms that his patient had, since they had almost the exact same deletion. I then went to local clinical databases and found another patient. We also tried to reach out to them. All this was done actually in the morning before I saw this patient. In other words, this is all the prep work that goes into actually seeing a patient in clinic. After this was all done, then I went to clinic. And I saw this, again, very beautiful boy. But indeed, he had all the issues that had been described in his medical chart before. He had a very large head, he had super hypermobile joints, and he was definitely delayed. I talked to his mom, and who was expecting to get more genetic tests that day, and I asked her to give me a week. I said, give me a week to see if this deletion might actually be the cause. In other words, maybe we've already found the answer and we just don't know it. Well, after that clinic, I came back to my office and there was an email. It was an email from the doctor in England. And he said that he had two boys and their mother, all of whom had the same X chromosome deletion, almost the exact one that we had seen in my patient. What medical problems did the boys have? Developmental delay, large head, and hypermobile joints. It was a perfect match with what I had just seen. Later on that very same day, I got a phone call, this time from the University of Texas Southwestern Medical Center. It was another physician who had seen a patient who had a similar deletion. This time again, it was a boy and his mother, both with the same X chromosome deletion. What did that child have? Developmental delay, large head, and hypermobile joints. It was amazing. They were exactly the same type of medical problems. Basically, what we had found was we had found a new genetic syndrome, and it had taken us less than 8 hours to find 4 people that had that on 2 different continents. This is the power of the databases that we hold, and also the power of the genetic testing that we can do. So what did I do next? Actually, the next thing I did was I picked up the phone and I called my patient's mom. I said, we think we do know that that deletion is the cause for his problems. We then talked about, well, what can we do about this? Well, because we knew that the deletion was the problem, we also could begin to help make a care plan for him, because we also knew what was happening with the other children. So the care plan for individuals who have this particular syndrome first starts with counseling. I could tell that mom that she was at 50% risk for passing this deletion on to a child. If the child was a male, it's likely that that child would be affected with something similar to their son. We also know, though, that individuals who have this, they will learn to walk, but it might be late. They will learn to speak, but it might be late. And they'll also definitely need some help in school. That's helpful because it helps us make that plan. I also could tell her that no genetic testing was required. In other words, we didn't need to do any more tests. We had found the answer. Do we need to do any other tests besides genetic tests? And the answer was no. No other testing or lab tests needed to be done. Was there any imaging that needed? No. And so it wouldn't be helpful for us, for example, to get a brain MRI or some other type of imaging test or X-ray, because that's not the type of problem that he was having. Did he need any special medication? The answer was no. These kids don't typically need any special medication, except if it's to help with their reflux disease, which is a little bit of a problem. Any changes in diet be helpful? The answer is in this particular case, no. This gene does not work as far as being a diet kind of gene. Will there be therapies that are necessary? Yes. We knew that physical therapy, occupational therapy, and speech therapy would all be useful. Were there any referrals that need to be made? In this particular case, he was already seeing a GI or gastroenterologist doctor because he had problems with his reflux. It was basically just he can't keep his stomach contents down. Instead, they keep on going back up and causing kind of acid burn. But he'd already had referrals for that. But we know that almost all the kids who have this will end up needing to have some help because of GI reflux. So what were we able to do? We were able to do less cost, less pain. That's the red stuff. And then we're also able to do things that would be more helpful for him. And so this is a child who, having a genetic diagnosis, actually made a difference in his care plan. And we would always hope that this would be the case. If we can know what's going on, we hopefully will have less cost, less pain, more help. The second family is a little bit different. Once again, a child who had developmental delay, some intellectual disability, but this particular child had a heart defect. He had an atrial septal defect, which is a hole in the top part of the heart, a ventricular septal defect, a hole in the bottom. He also had a special heart problem called left ventricular non-compaction. Basically, your heart muscle has to compact itself in order to be able to work correctly. If it doesn't go through that step, it becomes very loose and spongy and doesn't work the way it's supposed to do. This particular child had already had a chromosome microarray analysis, the first test I talked about, and had had a whole exome sequencing test, which is the second test I had talked about. When I saw him and we found out that these did not contain the answer, it was a little bit sad. I was really hoping that we'd be able to find an answer for him. But I said, why don't you come back and see me again in 2 to 3 years? And our hope is that by then, maybe we'll have new genetic tests. Or maybe we'll have found a gene that can answer what's wrong with this particular child. Well, about 3 weeks after that clinic visit, I got an email. This particular email was from the genetic lab. And they said they had found a mutation in a gene called Nono. It had not been previously reported, but they thought it was likely to be the cause. I said, why? Like, why do you think this is the cause? After all, just a few weeks ago, we had a report that said that there was no cause that was found on the whole exome sequencing. They said, well, we found another child who has a similar result and has similar findings. They said, can we anonymize him and send you his data, and you can tell us whether you think that that's a match? And so I said, sure, I'd be happy to review this child's findings. Well, what were the child's findings? They were developmental delay, intellectual disability, and heart defects. What heart defects? Atrial septal defect, ventricular septal defect, and left ventricular noncompaction. I shook my head and I said, oh my goodness, this is my patient. Like, you sent me the same data from the same patient. And they wrote back and said, Dr. Scott, this is not your patient. This is the other patient. I said, are you sure? Like, are you sure it's not just some kind of mix-up? And they said, guaranteed, this is a patient from a different institution, different last name. I said, this is it. There's no question it's a perfect match. In the end, we ended up finding out more about that particular family, and this is the other boy who had the same type of problems, actually on the other side of the United States. After learning that this gene did these type of issues, we found a third child. This child also had developmental delay, had some brain anomalies, so actual changes in the brain structure we could see on MRI, but it had those same type of heart defects. In fact, his defects were so bad that he had to have a cardiac transplant. And when we first learned of him, he was on the cardiac transplant unit. All these 3 children all helped us to define a new syndrome. This particular syndrome was, again, on the X chromosome. And so we were able to give families that have this the same type of counseling and help. So once again, I picked up the phone, made a phone call, and said, we know what's going on. This time the counseling is, again, a little bit different, but at the same time similar. There would be either a low risk if the mother did not carry this change, or up to a 50% risk if the mother did carry it. We know that children that have this will walk, they will speak, but they will definitely need help in school. No other genetic testing would be needed, and they don't need any other special kind of laboratory tests. They do need imaging, though. Every child who has this needs an echocardiogram. We actually found many children that had this disorder who had not gotten an echocardiogram, and when we learned that it caused heart defects, they ultimately got echocardiograms and found heart defects. Will they need medication? Yes. As it turns out, there are some medications that can help the heart to work correctly. And so those medications can actually help them to prevent them from getting into problems with their heart. Any changes in their diet needed? So no, this is not one of those type of genes. They do need physical therapy, occupational therapy, and speech therapy. They also will need referrals to cardiology, and they do have some significant GI or gastrointestinal problems. A lot of these children will need G-tubes because they do not feed well during early life. And if we can get them the nutrition they need, they can grow up to be healthy. So once again, a diagnosis leads to less cost and less pain, and also more help. Third family. This is a family I really loved. They were 2 very adorable children who came and visited me, and it was very obvious that they both had the same genetic disorder. We decided that we would help look for this disorder first by looking at the older sister. And so we did all of our regular tests, but we could not find an answer. I felt a little bit sad because I was sure that they had something that was genetic. But again, we had done all the tests that we possibly could. Over time, the other boy, so the brother, got testing at a different hospital. They did the same test we did, but they got a different answer. In this particular case, they found 2 changes in a gene called ADAT3. This is a very unusual gene. In fact, no one in the United States had ever been documented to have changes in this particular gene. But I wondered why one child could have changes in this gene and we did not identify it in the other child, since they seem to have the same problems. So I made a phone call to the lab. I said, how did we miss this? And they said, well, this gene is not well covered on the old version of this particular test. And sometimes we do have better versions of genetic tests that come out over time. They said the new versions can detect this change. That's why it was detected in the brother years after his sister got her test. And I said, well, is there a way that we can confirm these findings in the sister? And they said, we would be happy to do so. And so they were able to confirm those findings. And it helped us to understand what was going on for this particular family. And we knew that, again, she carried it and all the things kind of made sense. So the diagnosis was made of ADAT3 deficiency. What is this? Well, I made a phone call and told the mom, yes, we have the answer for sure. And then we were able to know from other reports that had been given about these children what we could do. In this particular case, the counseling was different. The parents both carried one each a change in this gene. And it was when each parent passed on that change to the child that the child then had no copies of this gene that were working. So the risk was 25%. We noticed also that children that have this do not typically develop verbal speech. They also have a very difficult time learning how to do signs. The mother in this family had actually found out something that was quite important. She noticed that her daughter seemed to do well when they used a flannel board to actually put up pictures. And so they got her a speech device. In fact, you can see that they're both wearing their speech devices over their necks on a little string. With those speech devices, they can actually communicate quite well. So for example, one time the daughter came walking into the clinic, saw me, ran up, jumped on my lap, and obviously wanted something, but I didn't know what she wanted. I asked the dad, what does she want? He looked at her and said, what do you want? She then took her speech device out, typed it in, showed it to her father, and her father says, oh, she wants your cell phone. I said, well, that's not going to happen. But at the same time, it's amazing. These are kids who would be completely nonverbal. But with a speech device, we're talking and learning about all the things that they need. We all know that these kids will also have poor growth. Both of them are very short, and they also have eye problems that require them to have glasses. So, is any more genetic testing needed? No. Any other tests needed? No. Any imaging? Yes. These kids can have problems with their heart, so they both need an echocardiogram, and they also needed to have a renal ultrasound to look at their kidneys to make sure that there were no problems. Any special medications for this? No. Any special diet for this? No. Diet will not help. What they do need is physical therapy, occupational therapy, and speech therapy that focuses on those speech devices. And they also need to be referred to ophthalmology for their eye problems. This is the pattern that we use now for kids who have this particular problem. Do you see how, again, over and over again, the diagnosis leads to a change in what we do? These families help us to know what can be done for other children. And so when a diagnosis is now made, instead of being 10 or 11 or 12 years old when they find these things out, we can begin to use speech devices right to begin with families. And so this has been a great help. So there's a whole bunch of different syndromes, a whole bunch of different genes that can cause problems with developmental delay, intellectual disability, or autism. These are just a few of them. Remember, there's thousands of genes that can cause this, and not all of them have a special name. But we want to know what a child has, and then can we match that with a specific treatment or treatment plan? So, what are the take-home messages for today? If you ask me what I think the take-home messages are, I think the first thing to remember is that we can make a genetic diagnosis in about 40 to 50% of all the children we see in our clinic. If you said, what about just those that have autism? If they have autism and developmental delay or intellectual disability, we can usually find between 30 and 40% of those we can find the answer. If they have other issues with their body, the percentage goes up. What about genetic tests? Well, genetic tests are improving all the time. And so sometimes families come in, they say, well, we had genetic testing when our child was 2, our child now is 12. Are there new tests? And the answer is absolutely. we can do tests that may be able to find something that was not found in the past. And we expect that in the future, we'll find more things as well, because we'll learn more about genes and we'll have better tests. Our knowledge of genes is expanding. These are 3 families that helped us to expand our knowledge of genes. On a regular basis, we find new genes in our clinic. At any given time, I'm usually, because I have an interest in this, I am usually working on between 40 and 50 genes that are likely to cause problems in children, but do not have enough evidence yet to prove it. Our knowledge of genes expands all the time. We find on average, as a community of doctors and scientists, we find 1 new gene every day. And so this is, again, something that's a great thing for the future. A negative test may someday yield answers. I think this is one of the most exciting things. We don't know your answer today. It's still possible that that same test, the same data that we got, will be able to tell you the answer in the future. And I think that's very exciting. When we think about reanalyzing data and also getting new data depending on kind of the situation for every child. And then last thing I think is the closing part. Making a genetic diagnosis changes medical management. It makes a difference in the things that we do. It also makes a difference in the things that we don't do. And both of those can be helpful. We really do want to limit pain. We want to limit costs, and we want to be helpful. One of the ways we can do this is by doing genetic tests and trying to find an answer for the why a child has their developmental delay, intellectual disability, or autism. Thank you so much for spending time with me today. I hope this is helpful. I hope that it'll encourage you to move forward and trying to identify the cause of your child's issues. Thank you so much.
Hi there. I'm Laura Buckner. I am a licensed professional counselor and a former special educator. I work at the Institute for Person-Centered Practices at the University of Texas at Austin. But I think my most important credentials are those last 3 letters. I am a parent of a 31-year, just turned 31 on the 4th of July, 31-year-old son with a rare genetic condition, of which autism is a common co-occurring condition. And so my years of parenting my son have taught me way more than any college degree ever could. So I am so glad that you've joined us for this webinar, and I am so sad that I am not in Laredo talking to you and meeting you personally, because I loved going to Laredo. We came there several times, and I just really appreciated the people I met in Laredo and the work that we were able to do. So darn it that we're not there. But thank you for showing up for this webinar nonetheless, because I want to show you some things, and I have to do this quickly. Don't have the hour that I would have had if I had been there in Laredo with you. But I want to show you some resources that I think are really valuable and important for families to be aware of, and I'll show you where you can access them for free. You know, if you think about, now I got to get my, there we go. If you think about when that child was born, you had a vision for what you thought that child's life might be like. You had dreams for that baby. You know, would he be a this, or would he be a that, or would he go here, would he go there? And then the diagnosis happened, as it did for many of us. My son was diagnosed at 3 months of age, and all of a sudden, your dreams are taken in a very different direction. And I know for me, it was very hard to imagine the future for him, because it was a very frightening prospect. But I want to show you what we call the trajectory. And this is not my personal brilliance. This comes from the work of a fabulous group of people at the University of Missouri. And you can access it if you just Google Charting the Life Course. And I'll show you a link for that at the end. Charting the Life Course, or Life Course Tools. You see the link down at the bottom of this screen. They call this the trajectory. We have to think about, what is it that we want for this child? What kind of life do we want for them? And if you look at the blue cloud on the top right, I think most of us would agree. We want this baby to have friends, family. We want them to have money in the bank, something they like to do that they might make money at, a place to live, their good health. We want them to have choice and freedom. All of those things that we think we want them to have. And those were our dreams when the baby was born, before the diagnosis. We have to reclaim those dreams, and we have to think about them in more specific kinds of ways. But the problem for many of us who have received what I like to call a scary diagnosis is that all of a sudden we lost sight of what our dreams were. We really can't envision what the future might look like for this child. If we try to envision the future for this child, sometimes it scares the world out of us and we quit thinking about it, because the future can be an intimidating and frightful set of possibilities. So if you are in that place and you don't know what you dream for this baby, this child, whatever the age your kiddo is, if you don't know what you dream for them, then start with what you don't want. If you can't think about what it is you do want, start with that green, scary cloud on the bottom, what you don't want. Because most of us can tell you in a heartbeat what scares us, what we don't want for our child. And if you know what you don't want, it directs you in a direction toward what it is that you do want. It helps you create that vision for what you do want. I hope that makes sense to you. Think about what you don't want. It's going to scare you, but let yourself go there for a little while, because it will lead you to thinking about what is it that I do want and what am I going to do about that to get there. If you think about what happens when a child is diagnosed with a disability or a genetic condition or both, their trajectory often starts to look very different than a typical child. Typical children go through some of these or these milestones on the bottom of this line. You know, they leave early childhood, they go to school, they're going to leave high school at some point at the age of 18 and go on to a life, and they're going to live an adult life. But for kids with disabilities or genetic conditions that cause chronic health care issues, often these milestones are critical transition stages that direct the child unintentionally to places you didn't want to go. And so I want you to think about, what is it that I do want? What is it that I'm afraid of? And then how can I direct a trajectory that's going to take them where I do want to go instead of taking me where we don't want to go? Because if you think about a typically developing child without that scary diagnosis, this is what their trajectory typically looks like. You know, when they're 2, they learn how to say no and say it a lot, right? They go to the birthday parties with their friends. They start maybe doing chores around the house, and maybe they make an allowance for it. They get into school and they play a sport or they play an instrument. They try Boy Scouts or Girl Scouts or a church program or whatever. They might have a summer job. All of those things are really important milestones in a typically developing child's trajectory. And even though your child might have a scary diagnosis, I want you to look at whatever age your child is. I want you to look at other kids who are the same age as your kid and see what they're doing. And then get as close to that as you know how to get. Now, here's the thing. It might not look the same. Your kid might have mobility issues. Your kid might have language challenges. Your kid might have behavioral differences. All of those things are part of a scary diagnosis, but they should not keep us from trying to get as close to a typical trajectory as we can get. So it might take longer. It might not look the same as a typically developing kid's. It might require more support, but figure out what other kids your child's age is doing, and then get as close to that as you can get with whatever supports and however much time it takes, because these are the milestones that lead your child to that meaningful life that you envisioned for them when they were born. So you think about wherever your child is, If they're 2 years old, 5 years old, 13, whatever age that your child is, you want to have this trajectory in your head. What is it we're shooting for? And how do I get there? What baby steps can I help my child take today that lead him or her to that blue cloud at the top, the things that I want for him or her, the things that I envision? And, like I said earlier, thinking about the future can be really frightening and intimidating, but you can start with baby steps. So, when your child is 2, a typically developing child is learning how to say no. Maybe your child doesn't have language and doesn't know how to say no. But you know what? They probably say it with their behavior. They probably know how to say no to you when you're asking them to do something they don't want to do. That's saying no. Empower that, encourage that, because saying no is an important life skill. And it's a life skill that takes your child in the direction you want them to go, toward a meaningful life. They make choices. 2-year-old can tell you if they want the Fruit Loops or the Rice Krispies. Give them opportunities to make those choices, because kids with disabilities need to learn how to make choices. Typically developing kids learn that at a very early age. I have worked with too many adults for whom somebody else made all of the choices, all of the decisions, and that young person has no idea how to make their own choice or live with the consequence of their own choice. They don't even know what their preference is because somebody else has made the choice for them. So those are baby step things that you could be doing right now, wherever your child is, that lead them toward that more meaningful life. I like to tell the story when my son David was entering the 6th grade. It was the first time he would have a choice between an elective of art or band. I thought that was a no-brainer. You choose art. No, he chose band. We have to honor that choice, even though I thought there is no way he could be. I don't know. We put him in band. The band director with IEP, you have to do what the IEP says, and he supported David brilliantly in band. David played the bass drum. I have no idea how that looked. But I will tell you that when it came time for the Christmas concert and they moved the whole band hall out onto the big stage of the auditorium, David totally panicked because it crossed his mind. Finally, it dawned on him that there was going to be an audience, and he couldn't bear the thought. He was just absolutely panic-stricken. And we all agreed, and he agreed, he did not want to be in a band concert, and we pulled him out of band. It would be easy to say, oh, Laura, that was a failure. You should never have let him try that. You set him up for failure. No, every other typically developing child had those same choices. There were other children who chose band and found out it wasn't their thing, or chose art and found out they couldn't draw a straight line. We all make choices, and we learn from our choices. Our children need those same opportunities, and to short circuit that, and we do it as family members, as service providers, we do it with the best of intentions. We make choices for them, and we don't realize we're short-circuiting their ability to make choices, learn from living with their decisions they made, to make better choices. That's part of that trajectory. So look at how a typically developing child develops. Get as close to that as you can get in whatever way you can get. This trajectory worksheet that I'm showing you is available for free download. It's in Spanish and in English. And they have several different kinds of trajectories, like what is a trajectory for a healthy life in terms of healthcare? What is a trajectory in terms of employment? If you're thinking about employment, whatever you're shooting for, you can tailor this trajectory tool to a specific goal or a specific issue. And again, it's on the lifecoursetools.com. And you can download these for free and work with them. There are some training videos online as well at that website where other family members will share with you how they've used these tools. And I'm going to wrap it up at that point by telling you this is who I am, and my email is at the bottom of this slide. And I want to welcome you that if you have questions about something that I said or need to find something that I talked about and can't find it, I welcome your email, please. Now, you'll have to tell me where we met on a webinar in Laredo virtually, because I do a lot of speaking, and I won't know who you are, but you'll say, when you said such and such, and I won't remember. So just tell me where you heard me, and then tell me what you're looking for. And I would be honored and humbled by your request, and do the best that I can to find the support that you're looking for.
We will send you a short evaluation by email and ask that you complete it. Let us know how you like these video conferences, and also suggest topics that you'd like to hear more about. Thank you very much for joining us today.